Well, if I could have everyone's attention, I would like to introduce our panelists. I thank them for not only participating, but also for eating quickly. And I'm sure they left some food back on their plates so that we could maximize the amount of time we have left. So we thought it would be helpful, as we've all been listening to experts on various aspects of HCU speak over the last 2 days, and we have allowed questions to be asked after each presenter. But we thought it would be useful to have a panel session and to take advantage of our two clinical experts we have, as well as 3 patients who we believe are great examples of successful management of HCU and dealing with the many challenges that it brings. So let me introduce the panelists, and then I will start out with a question to each to give you all time to come up with your own questions. And then I will open it up to the floor. Now, if there's something you'd like to ask and you are uncomfortable, write it out and bring it over to Danae, and she'll make sure that I get the questions as she finishes her lunch as well. So let me introduce the panelists that you haven't already met. Certainly you've met Dr. Chapman, our metabolic genetics, internal medicine, et cetera, expert from National Children's in Washington, D.C. You met this morning Dr. Levy from Boston Children's, a metabolic genetics expert and HCU expert as well. The 3 patient or caregiver representatives on our panel, just next to Dr. Levy, we have Sarah Sullivan. And Sarah is the mom to Colby and Kaylee? Kale. 2 patients who, despite having newborn screening done for HCU, were not diagnosed by newborn screening. They were diagnosed at ages 3 and 1. I'm sure Sarah will share more information to us, but unfortunately they were diagnosed because of a blood clot to the brain. And so that is the worst possible outcome when newborn screening doesn't work, and really gives us great reason to continue the good fight to improve that process. So Sarah will be able to represent the perspective of a caregiver, of a parent of young children with homocystinuria. Then we next have Pamela Penrose, and you heard Pam introduced yesterday by Danae as the oldest patient here with homocystinuria, who unfortunately was not diagnosed until age 54. But she has successfully managed her homocysteine and brought her levels from the 400s down to the 20s. So Pam, perhaps, perhaps you can share with us when I ask my first question your successful remedy to do that. And lastly, Kristen Rapp, who you were introduced to yesterday, a member of our board of directors, our vice president of the board, who's also a patient with homocystinuria, the first diagnosed through newborn screening in the state of Maryland. And she successfully manages her homocystinuria and manages to run marathons while doing so. So maybe that's part of her secret to success. But Kristen, we're all proud of what you've accomplished. So let me open up and first ask our 2 experts. You have heard Kim over the course of 2 days and Harvey over the course of today. You have heard many comments on how difficult it is for patients and caregivers to manage homocystinuria. If one of these patients or caregivers were sitting in front of you in your office, and you had the opportunity to tell them what you think the most successful way to manage homocystinuria is, what would the best piece of advice be that you could give them?
Please follow the diet. And be honest with me. It drives me nuts when someone comes in and I'm asking how things are going, and they're saying, oh, and giving me all the right answers for their diet and telling me all the medications and telling me how they're doing them. And I look at their numbers and that's not what I see when I'm looking at their labs. So please follow the diet and be totally honest with me. If you can't afford something, let me know. If you're not following the diet because of this, that, or the other thing, let me know and we can brainstorm together. But it's very hard without the diet, and it's very hard if you don't tell me where the barriers are.
Thank you. Dr. Levy?
Well, I'll echo what Kim just said, but I'll also add one other thing, and that is, in my mind, the most important aspect of the diet is drinking the formula. And I think that very often, the reason that the blood homocysteine level is high in people who say that you're following the diet is you're not religiously drinking the formula every single day, 3 times a day, completely ingesting the formula. So I think that's an extremely important part of the diet. As a matter of fact, it not only will get your homocysteine level down, even if you maybe not reducing the protein intake as much as you should, although that would be debatable, but it also tends to decrease your appetite for protein. So that if you're drinking a lot of the formula, you probably don't have an appetite for a lot of other foods, and I think that helps with the diet. But again, drinking that formula is critical.
Thank you, Dr. Levy. Let's now have Pam share with us. You had applause from the audience when they heard your success in bringing your levels down. What was your secret to success?
I think my secret to success was kind of trial by fire because when I was I was diagnosed at the age of 54.
Can you hold the mic closer?
I was diagnosed at the age of 54, and I really had no idea what I needed to do. I went to Stanford, and that's where I had my genetic test done. And then they did have me meet with a dietitian, but at that time, the dietitian really met with me more to introduce me to the different type of formulas that were available. And I didn't really get a lot of information as to how to proceed with the diet. So basically, I joined Facebook and got on some of the support group sites that are available on Facebook. And the dietitian in the area where I live gave me a copy of Virginia Schuett's book, which is actually for PKU, but it has a lot of relevancy to the HCU diet as well. And I read everything I could in the books that she gave me that give a lot of ideas of how to manage your protein levels. And I just kind of learned really from the friends that I met on Facebook, and then also just from the books that I was given. And I knew it was really important to take the diet very seriously because I had already experienced blood clots and I had experienced a stroke, and so I thought this is something I need to do, whether it may not have been my first thing I would have liked to have done, but I knew how important it was, and so doing that and then taking the formula really dropped my levels, and also the betaine too.
Thank you, and I'll go to Kristen, and then we'll come back to the caregiver perspective. Kristen, so what's your secret to success, and how do you run 26 miles in one day?
Staying on the diet is important, and also the formula, as Dr. Harvey mentioned. When I am running more consistently and training for the marathon, the doctor has asked me to increase the amount of formula that I'm taking. Similar to Pam, we also, in terms of adhering to the diet, we also follow those cookbooks and the advice on Facebook that we find. Even now, even though I've been on diet since I was very little, I still find new information from the support groups and more recipes. There's a lot more available. The Cook for Love site was really helpful.
Great. And Sarah, from the perspective of a caregiver of a parent who's had a more recent diagnosis, so you have access to much more information, electronically than, certainly than Kristen had when she was diagnosed 30 years ago. So how do you get access to everything you need, and how are you finding you're able to successfully manage your children's disease?
Well, with 2 kids in school, it's kind of difficult, but I think having a schedule and having the Facebook page has been really great. I've gotten a lot of good things off of there, and using the PKU networks that are out there have really helped us, like Cook for Love. Parents who share different things that they find at the grocery store has been really helpful. I'm glad that our kids are in the generation that they're in, and coconut milk and almond milk and all of those products are out there to help. I mean, they're helping us a lot. And then in Montana, there's not a lot of kids with metabolic disorders, but we do have one hospital called Shodair in the state of Montana, and they have a metabolic camp usually every year. And that's been really helpful just because we come together once a year, and there's nobody else with homocystinuria that goes, but there's lots of kids with PKU, and so I've gotten a lot of great information from that camp.
Great. So is the audience ready with any questions? And I guess I'll need someone to bring a microphone.
Thank you.
JP is going to offer. Thank you, JP. Do we have questions from the audience? Okay.
Can I
Malika?
ask Pam a question?
Oh, okay.
As an adult, how did you start drinking the formula? Because we all think of it as not tasting particularly good. It's easier as young children to introduce the diet. How did you make that transition?
Can you pass the mic down because we gave away our other one?
I have to say that it's not my favorite thing to have to do, but it is something that I know I do have to do. So I just kind of hold my nose and drink it. And when I very first got started with the formula, the dietitian sent me several samples of different types of formulas that were available. And I tried the different ones. I tried some that you put in the shaker bottles, and I tried some of the ready-made ones. And the best one for me that I've been very successful with, and I've been able to manage to drink, has been the HCU coolers, and I take the one with the 15 grams of the synthetic protein. And I knew I had to do it, so I just do it.
Okay. Malathi.
For Kristen, when you were running, I mean, when you increased
Hold the
your
microphone-
exercises.
Hold the microphone close.
Can you hear me? Oh. Yeah, I can. When you're training for the marathon, was that, I mean, doing more exercises, did that reduce the level at all, or increasing the formula made it go down? I mean, a lot of people say with the metabolic disorder, if you increase the amount of exercise, the levels are more, I mean, they are less than what you would have without those exercises.
Well, I can't really answer that for you because I don't get my levels done as frequently as some of the other patients. So I probably am not equipped to answer that question.
Can Dr. Levy or Dr. Chapman shed any light on that? And pass the microphone down.
Not an HCU. So the issue is it's not an HCU, so it's hard to say which is which. Now, we do know that probably the reason that drinking the more formula is because when you're active, you're burning more calories, and the last thing you want to do is start to break down muscle as you're doing that. And by running, you're going to break down some muscle, but hopefully that stabilizes out. I do know from a number of my patients that have PKU that we do have to increase their formula intake to increase the protein delivery that they get without the toxic protein or without the toxic amino acid, in part because they're burning so much and they are putting so much into their muscle, but there isn't data for HCU.
Anything to add, Dr. Levy? Okay.
Yeah, I mean, the problem is that people don't measure homocysteine levels very often. And also the problem is that measuring homocysteine is a relatively recent phenomenon. Going back quite a number of years, there was not the possibility of measuring total homocysteine. What was measured was cysteine, which is the disulfide, the two homocysteines together, which is not a very accurate measure of your total homocysteine by a very, very long shot. So, yeah, I mean, it would be a matter of doing those levels very frequently, and they're simply not done. If there was a simple method of measuring them, filter paper, for instance, method that was very simple, and that would be a goal that I think we'd all love to see attain, then that would be wonderful.
Other question? Okay, we have one in the back corner.
I know, and if Sarah doesn't mind me asking, I know we've talked about with your with Chloe and the blood clot, and if the doctors or anybody gave you any advice on having to avoid those, you had mentioned with an illness and dehydration, and I know with a lot of us flying has been one of my issues with my son, worrying about blood clots. Dehydration, you have young kids that are running around or getting stomach bugs and those. Have they given you any? I know I carry a letter that says if this child goes to the emergency room, we need to, run fluids open wide, get them hydrated. But any advice they gave you on keeping your kids from getting to that point where the blood will clot so easily?
The things that you've kind of already mentioned is just trying to not let them become dehydrated. We do have a letter too, so that we can provide that if they were to become dehydrated or need surgery emergently or any of those things. Colby does take an aspirin now, and they feel that as long as her levels are lower, bound that she doesn't get dehydrated or those kind of things, that she's not really at risk to clot. But otherwise, we haven't really been given a lot.
And let me ask if Dr. Levy or Dr. Chapman have anything to add on advice on avoiding blood clots, lowering risk for blood clots.
Well, it's the practical things to keep people from being dehydrated. Now, clearly, kids are going to get the stomach flu. They just are. And that's something that we're very aggressive with treating. We bring people in, we hydrate them, we make sure they can drink, we can make sure them eat to eat. But also simple things as kids move into grade school, make sure that their IEP or 504 includes being able to carry a water bottle or their formula bottle or both, and encouragement that the individual drinks throughout the day. And like preschool and kindergarten age, when the kids go to the bathroom, remind them to take a drink of their water or their formula, because those kinds of reminders just keep them active. When it's hot outside, build in breaks for them to drink extra fluids and make it just sort of, now it's time for our water break. All of those things, making sure that caregivers, if they're not parents, are aware that the kids have to sit down and drink, and potentially as individuals get older, give them goals. So during today, you not only have to drink your formula, but you also have to drink this much water, and figuring out a plan of how to do that are all kind of just practical things, and people stumble into those practical things, but that's just common things that you can do. And as I said, if it's a school-aged child, do actually build it into their 504 or their IEP. It makes a huge difference.
Yeah, I would only emphasize that overhydration is much better than underhydration by a long, long shot in homocystinuria. Don't worry about overhydration. I mean, sometimes you'll meet this sort of opposition in the medical community and say, well, we don't want to give too much drug because it may stress the body too much and they will get too much water and so forth. Well, as long as their cardiac function is good, exactly right. Kim says they'll pee it out, they'll take care of it. As long as their heart is fine, give them plenty of fluid. That is the key, I believe, to lowering by a long shot the risk for any kind of blood clotting.
Okay, we have another question in the back.
Hi, Pat. Oh, I'm sorry, and I'm going to grab one more. I think you talked about this a little with catabolism, like breaking down if you don't have enough protein. And we struggle with this when my son's 12, hitting the puberty, growth spurts, where I want to increase because we've gone through this when he was younger, where he wasn't getting enough protein, he was too restricted, and his numbers jump up. Do you have any thought on that? It depends which clinician I go to. They fight me on it, but you know, he's grown 6-7 inches in the last 2 or 3 years, and we have not increased his intake any. But his numbers are going up, but they don't want to. So at what point, and like you said, anything can change their numbers, but at what point do you play with higher numbers of protein intake so the body is not producing its own and breaking down its own muscle for protein?
Well, first of all, you got to make sure he's got enough calories going, because that's a very critical part of breaking down your body protein. But aside from that, yeah, I mean, is he drinking all of his formula? And I mean, does he really take all of his formula, or just sort of like takes it twice a day instead of 3 times a day, and instead of all 8 ounces, he only takes 5.5 ounces?
Yeah, he takes it every day.
And he takes all the formula every day.
Yep.
Yeah. Well, I think it's a matter of just struggling, because it's tough. I mean, I think it's easier to get your blood phenylalanine level down if you've got PKU than it is to get your homocysteine level down if you've got homocystinuria. First of all, the amount of methionine in homocystinuria is more restrictive than the amount of phenylalanine in PKU. I mean, PKU people can tolerate, if you've got classical PKU, you can tolerate maybe 250, 300 milligrams a day of phenylalanine. But I think in homocystinuria, you really aren't tolerating much more than about 100 milligrams of methionine. So it's tough, but you just got to stick with it.
And puberty is tough too, because puberty, you by definition have all these hormonal changes that change the way you metabolize through. So in some cases during puberty, people need a little bit more, and then after puberty, they drop back down. So the question is what the other pieces of data that makes them anxious are, because are you making enough protein? Do you have enough prealbumin? What do your other amino acids look like? That's all balances, and it's hard to say. But sounds like he's grown a lot. How much weight did he gain?
But yeah, he just had these growth spurts, and you know, it just shoots up. And he's always been, like you said about levels, we've always been under 50 since the day he was born. He's 12 years old, and now he's in the 80s. He's creeping to 100, and I'm not comfortable there. So that's just what I didn't. And we never changed his allowance, from food. So I know there's tons of factors that go into it. I just wanted to know.
So one of the questions is, can you get more calories into him?
And people have told me about these, because they always told us to use flaxseed oil for calories. Like, he doesn't like oils poured on everything. Someone said there's a supplement, a PFD calorie supplement that we can add. I'm like, oh, okay, well then we're going to try that kind of stuff, because he doesn't eat very much. He's never hungry because we just give him more formula, or, you know, he gets it that way, but the calories, I never heard that aspect of it, that can keep it from, we'll add the calories. Now that he's okay weight for his height, I don't worry about the calories anymore, but he's still lean. Okay, thank you.
We have another question in the back.
Okay, I'd like to ask regarding my niece. My niece is 18 years old, and she was diagnosed when she was almost 4 years old. I've seen a lot of people here with homocystinuria, and I have a huge question, because it's like kind of sad for me to see that my niece does not talk at all. She has no control of her pee at nights. She still wears diapers. She can't communicate. She can't be on her own. There's always, she always has to be with an aide, or, I mean, with my sister or my mother, or somebody has to be around her. She cannot function on her own. And I don't know if there's hope or if there's something possible for her someday to be able to talk, or if this is reversible, or that's just the way it is. And I don't know
Dr.
what else to
Levy,
say.
comment first? I know Kim, you commented yesterday.
I'll pass it on.
So one of the problems is control in the first 4 years of life. If you don't have really good control in the first 4 years of life, we know that individuals will have significant developmental problems, including speech. And I have a few patients that are older who were not controlled in the first several years of life. And so for them, communication is difficult, but they do interact. I tell people it's communication, not talking, that's more important. Several of them can't ask for what they want. And so that's very difficult. The urination issue, I don't have a solution for. But even in the adults that I have that have significant intellectual challenges, they do make progress. And control their homocysteine actually makes them better in terms of their emotional liability, whether they communicate. I can actually tell when somebody's homocysteine in this cohort is a little bit higher than it should be because they're much less interactive. But unfortunately, you don't gain things that you've lost back. As they do make progress, they still continue to surprise me in what they can do. And these are individuals that are in their 40s, 50s. But alas, it's hard to say that you're going to gain a lot. You may, however, make progress.
Yeah, I would agree with Kim. I mean, you know, don't give up hope, because if that level gets under better control, then you never can tell over a period of time. And over a period of time in metabolic diseases means years, not just months. But and could be many years, but even during that period of time, you can see some change in some of the metabolic disorders. That may be true of your niece. But the point I want to really make is one that I think should be addressed to you, Pat, and that is the variability in homocystinuria, the phenotypic variability. It's quite enormous. I mean, you can see that in this room here, where you have people who weren't diagnosed until, well, much later than 4 years of age, who are obviously highly intelligent, and yet you hear this story. So it really does vary tremendously, and I think it's one of the things the FDA will not appreciate because they don't really understand homocystinuria at all. In fact, many of them probably have hardly ever heard of homocystinuria, and yet they'll be making the decision based on the efficacy of anything, in this case, enzyme replacement therapy. So it becomes really very difficult. And if there was anything that I would emphasize to the FDA, it's really pay attention to the biochemical efficacy and not the clinical efficacy, because clinical efficacy can be all over the place, and clinical efficacy can take, as I said, a very, very long period of time, much more than the time that you'll devote to a phase 3 study. But biochemical efficacy is really the proof of the pudding. And we know that biochemical efficacy will, in most cases, mean clinical efficacy. If it's early enough, it's going to be better clinical efficacy. If it's later, then it may not be as good. But clearly, that's where the money is.
Can I just ask a follow-up question on the communication difficulties? Do either of you think that some of the techniques that are currently being utilized for autistic children to try to get them to communicate, and Disney songs and different things like that, do you think it's worth pursuing some of those approaches to see if there might be training techniques that could help her daughter communicate? And how would they go about that?
So I've seen this utilized in a cohort of a slightly different patient population that has homocysteine elevations as a component, and those families, the kids carry the autism diagnosis and get treated as though they have autism, even with their metabolic disease as the underlying cause. And I've seen significant advancements in their ability to communicate. So like Disney songs and learning through singing and learning through play and picture books where you're picking something out has greatly made them more communicative. And when they become more communicative, it is easier for them to cooperate with all the pieces that they have to do. So the answer is yeah. I think the advancements in autism therapies definitely play a role, especially the communication piece or the education piece. And there's several folks that carry the autism diagnosis, although technically they are not autistic because they have a metabolic disease, in part for us to make sure they get those services.
And I know that the metabolic clinic has never referred her to an expert to access those services. What type of specialist should they look for, or where would you go if you were the mother?
So we have an autism clinic at Children's National, so I actually send them to the autism clinic. Different areas will have different things. The folks that I'm thinking of off the top of my head have ADA, so Autism Development Association aides, who come into the household and educate in the household. These are often private companies, but sometimes they're sponsored by state programs, who this is what they do. And I don't know the ones in New York. I know the ones in Virginia and Maryland.
Yeah,
and
they're
so
in
I can do
Florida.
refer-
They're in
or
Miami.
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 So I don't know the ones
Okay.
in Miami.
Okay.
But I know the ones in my region. So potentially, we could try to figure that out. And they don't have names that make it really apparent that they are. I think one of the ones in Virginia is like Angels for You.
Yeah.
Like you're just,
Yeah.
you can't Google it. You just got to
Yeah.
know you're looking for it.
Yeah. Would you think going to a neurologist and getting worked up to
So I
see
think neuropsych testing might be actually more effective. Given her developmental level, though, a developmentalist might be better. The autism clinic is developmentalists and neuropsych testing at our institution with some additional support. But given the functional level, you're kind of between neuropsych and developmental. And depending on what people do in your area will depend on which is the better.
And I know Kim would be, very happy to help direct you to some of the organizations she's talking about who might know someone in Miami that could help you. Other questions? Do I see?
So I got a question here. My wife is up there in the middle. I promised her I'd ask one question.
It better be a nice one.
Yeah, and this is actually for Kristen and for Pam. It's a kind of a follow-up on Tara's question. I was speaking with Ben earlier today, and he said something that kind of rung true. It's you got to be your own advocate in this. So my wife's mother's intuition, and as with Tara, they're talking about something needs to be changed. Something, what can we do? As you've grown with this and you're in your adulthood, do you recognize when your body, when you need something and your dietitian's saying this is your allocated amount for the day? Do you know as your own advocate, do you I guess self-medicate here or there, it's something like, we're kind of going through that with our son, kind of what Tara is, he's always hungry, but we haven't changed their formulas for a while. So I'm just curious if you had any perspective in that.
Can you tell when your homocysteines are high?
I can tell when my levels are high just by how I'm feeling and my emotional state. I'm definitely a lot more emotional, and I don't handle situations.
Your husband's not denying that. But
Yeah.
In all seriousness, he patted me on the back first, though. So, disclosure.
So I can definitely tell, and also the people around me can tell, my family and my husband. So.
Actually, this isn't something that I really have been able to experience myself. I don't really see a lot of difference, although my husband may disagree. But I really can't tell if my levels are high or levels are lower, and that's just not something that I've really have had to experience.
other questions? We have one up here. Kristen's mom.
May I?
Yeah, please
May
add
I
on.
ask a follow-up question with regard to advocacy? Have any of you, or how many of you perhaps, have had difficulty getting funding for your formula? Has that been a big problem?
Yeah, we had a
'Cause we-
discussion yesterday.
Oh,
on
is that
that,
right?
yeah,
Okay,
yeah.
well
No,
then I
that's
won't
okay.
ask the
No,
question.
good. Well, we have a reimbursement advocate who we have contracted with, who spoke at lunchtime yesterday, Renette. And so we have an arrangement with her that all of the members of our community can access her support. And she knows how to work the system. And she knows how to short circuit the steps you have to go through in the system. So we encouraged everyone to reach out to her to help if you have not been able to get adequate reimbursement. But if there's something more you'd like to explore, please do.
No, I mean, it just hit me because we had a young woman who was just recently diagnosed with homocystinuria in her 20s, having been carried as an example of Marfan syndrome for all of those years, whose levels were very high, and the reason was because she couldn't get insurance coverage for her formula. It struck me that perhaps, I know certainly a problem in all metabolic disorders, certainly for PKU, and I'm sure for homocystinuria. But anyway,
Yes.
I just wanted to follow up on the question from the parents of adolescents and the change in diet and so forth. And many things may have changed. I'm Kristen's mom. But when she was going through adolescence and varied periods, her formula was changed. And it was not uncommon for it to happen. So I don't know why that would be any different now, since she turned out okay, but that's, I will just tell you that.
Just okay?
Phenomenal.
Any comment from the experts on?
We change our adolescent formula an awful lot. It's one of the it's one of the higher risk periods of time, but we also see them a little bit more. So we may see them less as older children, and then they often start having more and more trouble as adolescents. And then they disappear for a little while, and then they become young adults, and they reappear. And so, and their formula gets changed all over again a little bit. So, you know, it's a tough period. Girls are a lot harder than boys with this period because of the onset of menses.
Oh, to the reimbursement question, let me just add on. Danae has information on our website about some of the programs that exist. Like there was a foundation that the charitable foundation. All right, so in our next session, we'll come back to that and talk about that a little bit more. Yes.
Hi. I have a couple questions. The first, part of the natural history study, will there be a chart or categorizations of the gene mutations and what therapies would be eligible so we know if we can be hopeful about those things?
The answer is yes. There is a, if the individual who's participating in natural history study has not had his genes tested, that is, not had his genotype for cysteine beta synthase examined and reported, then we get a blood with permission from the patient to be sent for that particular analysis.
Okay.
Now, as far as using that information to target a particular gene or anything, that's a different story, because that does not have anything to do with enzyme replacement therapy. Enzyme replacement therapy should replace the defective enzyme regardless of what the genotype is, regardless of what the mutations that produce the homocystinuria are. But that is being done in a natural history study, yes.
Okay. When they saw our son, who's 5, his gene mutation, they said they were pretty sure he wasn't going to be B6 responsive. So I didn't know if there was ways to like categorize that and then know, if some of these upcoming therapies that they wouldn't work. Like,
So the answer is, once you know what the genotype is, we can often predict about whether this is likely to be a missense, nonsense, misfolded, not expressed kind of thing, and if that's what you're asking. So when you start talking about some of those other studies that are different from the enzyme replacement studies, genotype is going to play a big role in inclusion and exclusion criteria, because the expectation is certain genotypes would be more likely to respond to those therapies than other genotypes. So the answer is, yeah, that's going to come in handy as well, but it's separate from the natural history study or the enzyme replacement study.
And let me just remind you, though, that most of the promising treatments will work for all defects. So enzyme replacement therapy, the 2 alternative enzymes, gene therapy, maybe gene editing. It was really the protein activators like chaperone compounds, and those we have no idea whether they're going to work out or not. But I will give you one example of there's a chaperone product that was approved in Europe for Fabry's disease. And this company had to figure out which mutations in the gene that's responsible for Fabry's disease were amenable to therapy. And so they provided that to the FDA. In fact, when they first did their first phase 3 trial, they didn't hit the statistical results they needed because they were just learning which mutations responded. And then when they went back and took out those mutations that didn't respond, it then hit statistical significance. But it was a big battle with the FDA because it was post hoc. But the product has now been accepted by the FDA. It's not yet on the market in the U.S., but hopefully will be. But it is in Europe. So right within the product label, which is what clinicians will see in their references, they list the specific mutations that drug would be expected to work for.
But getting back to your comment with regard to B6 responsiveness, it may very well be that your physician was using the genotype to determine whether or not your child may be partially or more responsive to vitamin B6, not vitamin B12, sorry, yeah. Vitamin B6. And that is true to an extent. There are a few mutations, the most notable being the I278T, I believe, which are responsive to vitamin B6. So to one degree or another. So that if he does he have the I278T mutation?
He's not responsive.
Oh, he's not responsive in terms of clinical, but in terms of the genotype, was he questioning that in terms of the genotype? Would he thought one of the mutations might be responsive?
They believe that he would not be responsive.
He would not be responsive, that's right. Well, that would be, but if he had one of the 2 or 3 or 4 mutations that have been associated with B6 responsiveness, they might think that he was.
Right. So I see a lot of PKU people talking about getting blood tested weekly, and I wonder if they're over-testing or if we're under-testing to be more on top of our diet.
So PKU testing can be done on a paper filter card, which makes it really easy. And so you can actually mail that in. whereas the technology isn't there for total homocysteine. I think we can say that it would be nice to have more data in terms of homocysteines to help take care of patients. But it's a technical issue as opposed to, and do they overstudy? I have to tell you, in my practical experience, I've got people that are supposed to do it every week, and I just hope for every month. So I'm not sure if it's an over testing or if you have some really good friends who are really good at sending in their labs. With homocystinuria, it would be nice to be able to even ask the question as how much variation do we see week to week to week to week. But because right now it's a blood draw, and you have to come into clinic to get that done, it's much more complicated because if you don't live anywhere near clinic, or if you are like me and my practice is in DC and you have to drive an hour and a half to come into clinic, even though you're less than 10 miles away, then it's just not practical.
So perhaps if this technology we're funding through our grants program works to measure total homocysteine on the same card, then perhaps we can go on to see if technology like that might be feasible for at-home testing or mailing in, et cetera.
Okay, my last question. So my last question is about connective tissue issues and whether anyone else is experiencing knee pain as our 5-year-old is, especially after activity. But at one point when his levels were higher, he was shuffling and couldn't even do the stairs. I had to carry him. And we went through a battery of tests to exclude Lyme and arthritis and all sorts of things. It was all negative. So I can only attribute it to the connective tissue. Is there any solution to that? If he's in good control.
So the other problem we have is his age. Because kids at between about 3 and 7 can have growth pain, especially around their knees. HCU, there's certainly some connective tissue components with it, because if you think downstream, is cysteine. Cysteine is necessary for the cross-linking for a number of the connective tissue, the collagen, the glue that holds us together. And so that makes it more complicated. Trying to think in my cohort if I have a lot of people that is their complaint. I have people older adults that complain of joint pain, but the younger kids, I don't have a lot of really younger kids that are complaining about growth pain.
It's been about 2 years.
So our son, who's 7, he has a lot of leg pain, and they don't know why either. So we actually just saw a neurologist because we were hoping to get some answers, and he said, "Oh, his exam's normal. I really don't have anything to offer you." And so with him in the morning, his legs are really stiff. His bedroom's upstairs. He has a hard time coming down the stairs. It's like watching a 90-year-old man come down the stairs, and he's 7. So we've really struggled with that, and no one has any answers for us. So just thought I'd share.
Okay, we have one more question here, and then I have one more.
Well, I actually don't have a question. Just a comment about quality of life that we were talking about yesterday on one of the slides. And it goes to a sense of guilt and fear. Not guilt about genetics, but guilt and fear around mealtime for that parents and extended family feel. The only time I feel really good about feeding is when Silas drinks his bottle. There's often the sense that we're poisoning our child at mealtime. So that's just no question, just a comment.
Any reaction from anyone? Coping strategies?
Well, I don't know about coping strategy, but you certainly shouldn't feel guilty about having a child with homocystinuria any more than anybody should feel guilty about having a child with anything. We all have variations in our genes. They're all over the place. No two genomes, no two total DNAs are the same for any two people. We're all different. Well, yeah, I guess identical twins perhaps, but aside from that. You know, it's just a matter of, it's nobody's fault. It's just a matter of the throw of the dice, and you just happen to be in a family in which, going back thousands of years perhaps, this gene mutation occurred and has sort of gone through the family, and it just so happens that you have a child because you matched somebody else who had also a mutation in that particular gene for recessive. So one of the things that we constantly tell families is don't ever, ever, ever feel guilty over.
I don't feel guilty about genetics. I know they know part of that. It's mealtime.
Oh, you're talking about the feeding. Okay. Don't feel guilty about anything.
Are you feeling guilty because they can't eat what they may want to eat?
No, it's a guilt over the specifics of the diet. Make sure that we're not going above or below.
Okay.
And then when his grandmothers feed him, the fear and guilt that they have that they're poisoning him.
Okay.
And that's what comes to my mind, is that I'm poisoning my son when I'm feeding him.
So any suggestions from the parents or patients in terms of what gives you the comfort level that what you're feeding your children is okay, and is it consistent with the dietary recommendations?
I have to say I have some of the same feelings that you do, and I feel like over time it's gotten slightly better. After our kids were diagnosed, you know, they had been eating regular food. My daughter did until she was 3, and so we had to abruptly change things. I literally ate dinner behind doors because I didn't want to eat in front of them, because she knew what mac and cheese was. She knew what some of the other food was, and she wanted to eat that, not what we had given her. And I had all that guilt. I could not eat dinner in front of them. I just had a really hard time. But I think over time, as she's gotten older and can, you know, relay her feelings more, to me it's gotten a little bit easier, because she likes some of the things that she's eating, and she even said just the other day that she didn't want her diet to change. She said she liked her diet and she liked being special, and she didn't want it to change. So she's really gotten comfortable with it, and we just try to celebrate the small wins. We just came up with a BLT sandwich, which some of you probably have already done, but with Morningstar bacon and some gluten-free bread and guacamole, and they thought it was the best sandwich ever. So the small wins for us, we've just tried to make a big deal out of.
Okay, one more question, and then I'll ask the final one.
No, this wasn't a question. This was a response again. Please don't feel guilty for your child. If I had any recommendation at all, I would say just always be sure that there's something special for them to eat, whatever meal it is that's, you know, they like, and that you don't have to feel guilty about them eating. And, you know, not as a mother of a 40-year-old, we didn't have as many food choices as you do now. But what we did have, whether it was the muffins that was in the one cookbook I knew of, I made sure to have, or whether it was a birthday party where she had a fruit bar versus the ice cream and cake, I just always made sure there was something she liked. So as long as you're providing that, I don't think there's any reason to feel guilty, and your child's not going to feel bad either.
Okay, thank you for that. So let me just ask the last question of our two experts, and we'll have Kim go first so that Dr. Levy can handle his phone call. So my final question is, what gives you the most hope about the future of homocystinuria?
Actually, how involved the patient support and family groups are.
And I didn't even pay her to say that.
Because sometimes it's really frustrating taking care of patients with a rare disorder in which the families don't have the support and they're not quite as engaged. And so I think that is potentially one of the best things, and the thing that gives me the most hope, because families is the way that we come up with therapies, and if you participate in research, and if you play a role in the clinical trials, and you support each other, it allows us to help take care of you. And one of the things people forget is, I'm sure Harvey would agree, is taking care of individuals with homocystinuria is a wonderful thing. We really enjoy it. We enjoy being with you through the journey. And you give us as much as we give you. So we may give you time and we may give you brain energy, but you give as much back to us as we can possibly give to you.
I couldn't agree more. Absolutely, Kim. But let me tell you, there are three things that give me hope. Number one is this family group. The fact that you've gotten together as a family and you have an organization. And by the way, Margie, you've done a magnificent job of bringing everybody together. Absolutely magnificent.
Well, thank you, but Danae has really done all the work, and Kristen has done a great support.
So it's so important, and that gives me great hope for the future. Number two is the new therapies that are coming down that Dr. Orn has spoken about, and of course, that Margie has described. And there's tremendous hope for new therapies. And thirdly, the diet. The diet is getting better. I don't know if David and Lynn Paolela, are you still here?
Yep.
Oh yeah, there they are. Camp-Brook has been marvelous. I can tell you that going back before Camp-Brook, people with PKU and homocystinuria, for that matter, and all the other metabolic diseases, all you could eat was salads and French fries. And that was it. And the diet was just god-awful boring. Just terrible. And the formulas tasted even worse than they taste now. Believe me, they taste wonderful compared to what they used to taste like. So this is it's been so all of those things have just been a sea change in terms of taking care of metabolic and control of metabolic disorders. But we still have a long way to go, and I'm hopeful that all of those things together will point us and are pointing us in the right direction.
Well, thank you, and thanks to our Lynn wants to.
I just want to add one thing. I don't know if you even remember this, Harvey. 25 years ago this year, Karen Lewis, myself, became involved with Children's Hospital, a group of families, to start the New England Connection for PKU and Allied Disorders. And we're celebrating our 25th year this year. But it really was, it began with a group of really concerned clinicians, concerned parents. We joined forces, and eventually you would let us, lead the way, and you kind of backed back. But, it's been really amazing.
Great, thank you. Thank you, thank you. Well, thanks to our panelists, especially our two patients and caregiver putting themselves out there, and our two experts. And I can't tell you how important it is to have Dr. Levy and Dr. Chapman here at the meeting and listening to all the sessions and participating and adding comments. This meeting would not have been anywhere near as good as it was without your expertise and your compassion and your empathy. So join me in thanking them in case they're not here at the end.